We can send like microscopic cameras through our veins and literally map the entire human genome, but yet the exact functional anatomy of female sexual health is still, right now, undergoing basic discovery.
Yeah, it's pretty staggering when you put it in that perspective.
It really is. So welcome back to the deep dive. We have a highly specific mission for you today. We are looking at a really fascinating stack of sources. We've got anatomical cadaver studies, MRI data, clinical protocols for regenerative therapies, and surprisingly, even some veterinary research in here.
This is a fun twist.
Definitely. And we are taking all of this to answer one very targeted question for you today. Can ultrasound-guided injection techniques improve the accuracy of PRP deposition around the clitoral bulbs?
What's fascinating here is that we are looking at a massive paradigm shift in how medicine approaches this entire region of the body. I mean, for decades, treatments in this specific anatomical area relied heavily on what we call blind medical techniques.
Right, just kind of feeling around.
Exactly. Essentially making highly educated guesses.
Yeah.
But when you start combining regenerative therapies like platelet-rich plasma or PRP with real-time imaging like ultrasound, the entire landscape of what is possible in sexual wellness just fundamentally changes. We are moving from guessing to actually seeing.
To really grasp why that shift to visual imaging is so necessary, we first have to understand the actual terrain a doctor is trying to navigate. Because, you can't hit a target if you have no idea what the target actually looks like.
Right, that's step then.
And based on these sources, this terrain is largely hidden from the naked eye.
The clitoris is notoriously misunderstood in general anatomy, mainly because the vast majority of the structure is internal. To give you an idea of how much effort it takes just to see this anatomy clearly in a living person, one of our sources details a highly specialized MRI imaging protocol.
And it is not a simple process.
No, not at all. To get clear images, practitioners sometimes have to place gauze between the labia and actively insert 60 milliliters of ultrasound gel into the vagina via a catheter.
Wait, 60 milliliters of gel? Just to take a picture, why is all that necessary?
It comes down to creating contrast.
Mm.
The soft tissues in the pelvic region are incredibly dense, and they tend to just rest against one another. So on a standard MRI, it can just look like a gray blur.
Like trying to find a shadow in the dark.
Exactly. By introducing the gel, they create what's called an acoustic window.
Yeah.
It physically separates the internal structures and provides a clear medium for the imaging waves. And that finally allows us to see the organ in 3 dimensions.
And when they finally get that clear 3D picture, it completely shatters the common perception of what the clitoris actually is. The MRI reveals it is not just a tiny surface structure. The sources describe it as this angled, boomerang-shaped body.
Very large boomerang, comparatively.
Right. It extends about 4 inches deep into the pelvis, and they mention looking at it through different planes, specifically sagittal and coronal. For anyone who doesn't spend their days looking at medical scans, a sagittal view is basically looking at a slice of the body from the side, while a coronal view is looking at it straight on from the front.
And looking at it from those varying angles reveals just how multi-layered it really is. It sits right at the undersurface of the pubic symphysis, which is the joint between the 2 pubic bones.
So it's anchored right there.
Yes. And the coronal view, that front-facing view you mentioned, shows 2 distinct bodies, or corpora, uniting into a single structure.
It's just this massive, complex network, but to really understand the microscopic details of this hidden network, researchers had to go even further than MRI scans.
Because MRI only shows you the macro view.
Exactly. There's a cadaver study in our stack by Ginger and Yang from the University of Washington that just blew my mind. They took 10 cadaveric vulvas to map the exact pathways of the nerves, but they couldn't just dissect them normally. They had to treat them with distinct chemical solvents.
And the methodology they use there is vital to understanding just how intricate this anatomy is. They used an ethanol-based solvent specifically to hydrate and preserve the nerve tissues, and a chloroform-based solvent to keep the muscle layers intact.
But the really critical step was using a xylene-based solvent, right? I was wondering about the xylene. What does that actually do to the tissue?
Xylene has this incredible property where it makes fat and skin virtually translucent.
Oh, wow. See-through fat.
Yeah. Think about trying to find a tiny white thread inside a dense block of yellow fat. It's nearly impossible. By using xylene to clear away the visual obstruction of the fat, They could map the exact pathway of the dorsal nerve of the clitoris, the DNC.
And they did this under microscopic magnification.
Right, without accidentally cutting or moving the nerve during a physical dissection, which is incredibly easy to do.
The precision is just wild, and what they discovered by making the fat see-through is that these nerves aren't just scattered randomly throughout the tissue. The dorsal nerves travel along the clitoral body at highly specific points.
Very specific coordinates, basically.
Yeah. If you imagine the cross-section of the structure like the face of a clock, the nerves sit exactly at the 1 o'clock and 11 o'clock positions. And at the base, they found these nerves are just 4 to 8 millimeters superior to the tunica.
And we should clarify the tunica for a moment. The tunica albuginea is a tough, fibrous sheath that wraps around the spongy internal tissue. So these tiny nerve bundles are sitting just millimeters above that tough outer layer.
Okay, let's unpack this. Think of it like an iceberg, right? We only see a tiny fraction on the surface, but the rest is deep, complex, and highly specific. 4 to 8 millimeters is less than the width of a pinky nail.
It's incredibly small.
So if a doctor is coming in with a needle, trying to deliver a treatment, and they're just feeling around and estimating where this invisible nerve is, how much room for error are we talking about?
Virtually none. Because the target is literally millimeters wide, any natural variability in human anatomy makes estimating highly unpredictable. What sits at 4 millimeters in one patient might sit at 8 millimeters in another.
So you could just miss it entirely.
Easily. You are aiming for a microscopic bundle of fibers deep beneath the skin. This complexity is exactly why visualizing and training on these internal anatomical structures requires such specialized educational tools.
Which explains the 3B scientific catalog included in our sources.
Yes. 3B Scientific Designs Complex, 3D medical simulators. You simply cannot grasp the spatial relationships of this specific organ by looking at a flat, 2D textbook drawing.
Right, a drawing doesn't show you depth.
Exactly. Doctors need physical, three-dimensional models to understand how that boomerang shape curves around the pubic bone, just to begin conceptualizing where a needle should actually go.
So now that we have a mental image of this highly complex, hidden terrain, we really need to talk about what practitioners were actually trying to deliver to those nerves. The payload, so to speak.
Which is the whole point of navigating the terrain.
Right. We are talking about PRP, platelet-rich plasma, which is often marketed in clinical settings as the O shot.
To understand why PRP is used, we have to look at its mechanism of action. PRP is a form of regenerative medicine. It involves taking the body's own innate healing factors and heavily concentrating them.
As opposed to just fillers.
Exactly. You might hear about other treatments using hyaluronic acid in this area, which acts as a pop filler. Hyaluronic acid is great for retaining moisture and plumping the tissue, but it's temporary. PRP is fundamentally different because it is focused entirely on cellular regeneration.
The actual clinical protocol for how they prepare and deliver this is intense. According to the sources, the entire process starts with a specialized numbing agent called BLT cream. That stands for 20 to 30% benzocaine, 6 to 8% lidocaine, and 4 to 6% tetracaine.
And the reason they use that specific cocktail of 3 different anesthetics is because each one penetrates the tissue at a different speed and depth.
Oh, that makes sense.
Yeah, they massage it in and leave it under plastic wrap for an hour to ensure it sinks as deeply as possible. The sources note that sometimes they even use an ice pack and inject a direct lidocaine block beforehand.
Just to be absolutely sure.
Right. The goal is to ensure the areas are completely desensitized before they begin the actual procedure.
While that numbing process is happening, the clinic prepares the PRP. They draw a relatively small amount of blood from the patient's arm, usually about 10 to 20 milliliters. That blood goes into a centrifuge for 5 to 10 minutes.
Which is a crucial step.
Right. For anyone who hasn't seen one, a centrifuge spins the vials incredibly fast to separate the fluids based on density. The heavy red blood cells sink to the bottom, the clear plasma sits on top, and right in the middle is this golden layer, the platelet-rich plasma. They extract about 3 to 5 milliliters of that pure serum.
But they can't just inject it yet. The platelets in that serum are basically dormant. They need to be tricked into thinking there is a wound that needs healing.
So they have to turn it on, basically.
Yes. They chemically activate the serum, typically using 0.2 milliliters of 10% calcium chloride. That calcium chloride is the chemical key. It causes the platelets to rupture and release their growth factors.
So now they have this activated regenerative serum. They inject about 4.5 cc into the anterior vaginal wall, near the area typically associated with the G-spot. But then they take a tiny amount, about 1 milliliter, and inject it directly into the clitoral corpus cavernosum, which is that spongy, blood-filling tissue inside the boomerang shape we talked about earlier.
And the ultimate biological goal here is that for up to 7 days post-injection, those ruptured platelets continuously release growth factors into the surrounding tissue.
Or a whole week.
Up to a week, yeah. This stimulates two distinct processes: angiogenesis, which is the creation of brand new blood vessels, and neurogenesis, which is the growth and repair of nerve tissue.
Here's where it gets really interesting. So it's essentially acting like liquid fertilizer for the cellular root system.
That is a very apt way to describe it. It's enhancing the tissue at a fundamental cellular level to restore or increase lubrication, sensitivity, and the overall orgasmic response.
Now, before we move on to the actual injection mechanics, there's a very specific argument made in one of our source texts that we need to address.
Yes, the regulatory context.
Right. The author of this particular piece expresses intense frustration regarding how the FDA handles sexual health treatments for men versus women. They point out that men currently have over 20 approved drugs and devices for sexual dysfunction, which they state only require proof of a physical response like the mechanical ability to achieve an erection.
While the requirements for female treatments are fundamentally different, according to the author.
Exactly. On the flip side, they argue that women have only one approved drug, a psychiatric medication, and that the FDA requires proof of emotional satisfaction for female drugs. The author argues this is a profound double standard in modern medicine.
It is a major recurring theme in that source text. And we are, of course, just imparting the arguments presented in the material without taking a stance on the FDA's regulatory framework ourselves.
Absolutely. We are just looking at what the source says.
But understanding that author's underlying point is crucial context. The argument is that this disparity in widely available FDA-approved treatments is precisely what drives so many patients and practitioners to explore off-label regenerative options like PRP to address female sexual dysfunction.
Because when traditional pathways are limited, people look for alternative solutions.
There you go.
That sets the stage for why the O-shot has gained such traction. But let's look at the mechanics of the injection itself. The sources describe the clitoral tissue acting, quote, like a sponge. The idea is that when that 1 milliliter of PRP is injected, the spongy corpus cavernosum naturally pulls the serum in, distributing it throughout that unseen 4-inch anatomy.
It soaks it up.
But if I can push back on this for a second, if the tissue naturally acts like a sponge and just soaks up the liquid anyway, why are we so concerned about exact millimeter-perfect needle placement? Can't the doctor just get it in the general vicinity?
If we connect this to the bigger picture, it's a fair question, but it really comes down to the physics of concentration. Yes, diffusion happens within spongy tissue, but think about those tiny microscopic nerve bundles running exactly at the 1 and 11 o'clock positions.
The ones that are just 4 to 8 millimeters deep.
Right. Delivering those concentrated growth factors directly to the dorsal nerves guarantees the maximum possible dose of regenerative agents exactly where they are most needed. If you just inject it generally and rely solely on the sponge effect, the fluid might distribute unevenly or settle in areas with less nerve density.
So it dilutes the effect.
Exactly. You are hoping the fluid finds its way to the nerves rather than deliberately placing it there.
And if you are relying on hope, that brings us to the real danger of doing this without visual guidance. What actually happens when injections in this highly complex pelvic region are done blind? Because traditionally, pelvic nerve blocks, like a pudendal nerve block to stop pain, rely on what the medical field calls anatomical landmarks.
And anatomical landmarks essentially mean using your fingers to feel for specific bony prominences through the skin or tissue.
Just pressing on the skin.
Right, and using those physical markers to guess where the underlying nerves should be based on textbook averages.
And the data in our species shows that guessing based on averages has huge limitations. There's a randomized controlled trial by Hurdle et al. In the stack. They wanted to compare ultrasound-guided pudendal nerve blocks against traditional fluoroscopy.
Which is basically a continuous real-time X-ray machine.
Right. They found that while traditional methods can work, they inherently lead to massive variability in success rates and a much higher risk of complications. Because even with an X-ray, you are mostly seeing bone. You can't see the soft tissue, meaning you are still basically navigating in the dark.
Navigating soft tissue blindly is incredibly challenging, which is highlighted by a wildly interesting veterinary study in our sources.
Oh my gosh, yes.
Researchers didn't just look at humans to prove the flaw of blind injections. They looked at an equine cadaver study, horses.
This was my absolute favorite study in the entire stack. Explain how they used to do this in horses, because it is wild.
Traditionally, veterinarians used a completely blind technique to inject the pudendal nerves in horses. To guess if their needle was in the correct spot, they would actually watch for muscle twitches.
Muscle twitching.
Yeah. They would advance the needle and look to see if the external anal sphincter or the perineum twitched. If it did, they assumed they were close enough to the nerve and injected the medication.
It's literally like playing pin the tail on the donkey while blindfolded. You generally know where the tail is supposed to go based on the overall shape of the animal, but you are absolutely still just guessing based on a random twitch.
Honestly, yes.
Okay.
It sounds ridiculous, but that is a highly accurate way to describe the mechanics of relying on a muscle twitch. And what this equine study proved was just how ineffective that guessing game is. They found that this blind twitch method frequently resulted in incomplete blockades.
Meaning it didn't numb everything?
Right. Most notably, the needle completely missed the third pudendal branch, which happens to be the dorsal nerve of the clitoris or penis. The medication just didn't reach it.
They missed it entirely.
Entirely. But by contrast, when those same veterinary researchers used a transrectal color flow Doppler ultrasound on live donkeys, they achieved a 100% success rate, even at a depth of 80 millimeters into the tissue.
100% success rate simply by turning on a screen. I mean, if blind injections are routinely missing the dorsal nerve of the clitoris in a massive animal like a horse, where you'd assume the anatomical structures are much larger and easier to hit, it totally underscores how easily a doctor doing a blind PRP injection could miss that tiny 4 to 8 millimeter window in a human clitoris.
It highlights a universal anatomical truth across species. Without direct visualization, avoiding critical structures and hitting micro-targets is essentially a game of chance.
So how exactly does ultrasound fix this problem for human PRP deposition, and what does it actually look like in practice?
The advantages of ultrasound in a clinical setting are massive. First, it completely prevents radiation exposure, unlike the continuous X-rays of fluoroscopy. Second, modern machines are incredibly portable. And most importantly, it allows for real-time, high-resolution visualization of the needle's exact path.
Like watching a video game.
Yeah, the practitioner can watch the needle move through the tissue on a screen, allowing them to actively avoid puncturing critical intrapelvic blood vessels while navigating straight to the target nerve.
We have a fascinating case study demonstrating this from the International Society for the Study of Women's Sexual Health, or ISSWSH. Researchers used a very specific setup, a Philips Lumify ultrasound with an L12-4 linear array transducer.
Which is quite advanced but very compact.
Right. For context, this isn't one of those giant, intimidating machines wheeled on a cart. A linear array transducer is basically a high-frequency wand that is perfect for scanning shallow structures just beneath the skin. And the Lumify system literally plugs into a standard tablet or smartphone.
It's brilliant.
It makes this technology incredibly accessible for a normal clinic. So they tested this on a healthy 32-year-old volunteer. What exactly were they looking for on the tablet screen?
They were looking to measure blood flow before and after the injection, both qualitatively and quantitatively. They use color Doppler imaging, which overlays bright colors onto the black and white ultrasound to show the actual direction and speed of blood moving through the vessels.
Okay, so seeing the actual flow.
Right. And they measured two specific things. First, the peak systolic velocity, which is the maximum speed the blood travels through the deep artery of the clitoris with each heartbeat. And second, the resistive index, which measures how much resistance the blood faces flowing into the tissue.
And the evidence of efficacy they captured is striking. The sources note that when PRP injections are successfully targeted using this method, it literally changes the ultrasound waveform on the monitor.
The waveform data is undeniable. The text vividly describes the ultrasound waveform changing from what looks like a flaccid penis to an erect penis on the screen.
Just a total structural shift.
It visually proves that targeted placement physically alters the hemodynamics of the clitoris. You are watching the tissue wake up and engorge with blood in real time. It's not a subjective placebo effect. It is a measurable physical change in blood velocity.
But to be fair to the whole picture, ultrasound isn't a magic wand. We have to talk about the limitations.
It has very real limitations. As the Hurl study pointed out, ultrasound-guided approaches inherently take longer to perform, especially when a clinic is first adopting the technology. There is a steep learning curve.
Because it's not intuitive.
Right. It requires serious hand-eye coordination for the practitioner to move the needle in their hand while staring at a screen, interpreting those grainy black and white waves.
You have to mentally translate a 2D image back into a 3D physical action.
Furthermore, the equine study noted a limitation born from the physics of ultrasound itself. As you push the sound waves deeper into tissue, say, going 10 to 15 centimeters down, the image resolution fundamentally degrades.
It just gets blurrier.
Exactly. If a practitioner isn't highly skilled at interpreting low-resolution images at deeper depths, they could misjudge the needle tip's location. The technology is only as good as the training of the person wielding it.
So what does this all mean? Let's bring this all together. If someone is looking into a clinic that offers the O-shot or a similar PRP regenerative therapy, should they be demanding that the doctor use an ultrasound machine?
Our sources don't go so far as to mandate ultrasound for the O-shot across the board. There are many skilled practitioners who still use anatomical landmarks with reported patient success. However, the data heavily implies that visual guidance transforms the procedure from a well-educated guess into a precision strike.
It takes the luck out of it.
Yes. If the biological goal is to bathe the dorsal nerves at those precise 1 and 11 o'clock positions with growth factors, ultrasound drastically improves the accuracy of that deposition.
It completely takes the guesswork out of the equation. So, let's quickly summarize what we've uncovered. We started by mapping the unseen terrain. We learned the clitoris isn't just a surface bump. It has a deep, complex, boomerang-shaped anatomy extending inches into the pelvis, with nerves situated in millimeter-wide corridors above the tunica.
Right.
We explored how PRP uses concentrated growth factors, activated by calcium chloride, to act as cellular fertilizer for new nerves and blood vessels. And finally, based on nerve block studies across both humans and animals, we saw that utilizing ultrasound guidance replaces blind luck with visual certainty.
And looking at all of this data raises an incredibly important question to mull over as we wrap up. One of our sources referenced an MRI study published in the Journal of Sexual Medicine. That study showed a fascinating correlation.
Wow.
Women who easily achieve orgasm naturally tend to have a clitoris that is physically larger and anatomically situated closer to the vaginal wall.
Meaning the physical, structural anatomy itself dictates the functional ease of the response?
Exactly. Now consider everything we just discussed. If ultrasound-guided PRP accurately targets the corpus cavernosum and successfully triggers angiogenesis and neurogenesis, literally growing new nerves and blood vessels, could the future of this treatment go beyond just temporarily improving sensation?
Oh, wow.
If we're actively growing new tissue, could highly targeted regenerative medicine actually permanently alter the physical, structural anatomy of the clitoris over time? Could we fundamentally make orgasms easier to achieve by physically changing the size and proximity of the organ itself?
That is a wild thought to leave on. We started this deep dive talking about how we've mapped the human genome, but we are still discovering the frontiers of human anatomy. It turns out we aren't just discovering the map with tools like ultrasound or regenerative medicine. We might actually be learning how to redraw it. Thank you so much for joining us on this exploration. Keep learning, keep asking questions, and we will catch you on the next deep dive.